Good morning. So I'd like to welcome you to our 8th eConsult webinar. And today we have Dr. Mike Leveridge with us talking about the specialty of urology. So Dr. Leveridge has been with the department for almost 12 years now and has been with the eConsult service for approximately since 2019. Processing about 120 eConsults a year. He's got lots of experience under his belt, and we certainly look forward to learning from you this morning about how primary care can incorporate eConsult in the practice as it relates to urology. I'll hand it over to you now, Mike.
Thanks so very much. I will share my screen now. My name is Mike Leveridge, as you've heard. Thanks very much for this. It's I've really enjoyed my eConsult thing. It's it's a communications distillation, usually sort of very very specific questions, which are always sort of soothing to sort of stimulus response and use your brain to think of the best way to help out. As you'll see, there's a varied group of types of questions, but I think the theme here is that in trying to decide what is a great eConsult, what is maybe a less one, I think the sort of, what's the word I would use, the survivorship effect, the fact that the ones that come up as they do, I think they've sort of self-selected as good consults. There are a couple of us who do eConsults in the department. That probably does leave a gap or two in things like pediatrics, etc. But very happy to be engaged in the consult service, and very happy to see a technological thing that works. When you click buttons, you go to the place you expect to be, and then you do the thing, and then you leave, which is not what we're used to in most of our administrative and para healthcare lives. So my thanks for the invitation here, and we'll be ready to get cracking. Some disclosures first, and I'll let this slide linger. I've got a hypothesis that's probably borne out by some research somewhere that disclosure slides last about a quarter second, and that no human could possibly read fast enough for a disclosure slide to be left up. And you'll see Janssen and Baer there. I did more than 2 years ago give a couple of lectures for Pfizer as well. The Janssen and Baer things were adjudicating sessions with other experts speaking on advanced prostate cancer, not germane to today's discussion. And I have provided a few talks on various things, including virtual clinic management for the Canadian Urologic Association. And I have a couple of recent and administrative roles with them. The objectives here, I think objective 1 is really the thing. Objectives 2 and 3 are sort of bigger picture objectives, and I'm not sure today we will manage patient needs effectively through eConsult, but I hope that they are, and I'll show you a little bit of data around that in the next couple of minutes. And identifying the relevant opportunities. So that's the thing here, and going through these sessions, it's oftentimes, what do we see, what makes a good one, what perhaps makes a little bit of a lesser one, specifically to the text-based e-consultation between care providers and specialists. This is the urology versus the e-consult data. My numbers, sure, I'll have a quick look at as well. I think the big thing here on this slide is if you can see my pointer, and if not, it's the 254% here in the row 2 of the actual table meat, suggesting that good advice or an additional course of action. I mean, I don't know what the ideal number would be. I would suggest that if that number were 100% here, then it would probably imply that there are some missing opportunities for consults and efficiencies out there. But 50+% receiving good advice, an additional course of action, that seems to be a pretty excellent validation of the eConsult thing in the urology world, whether it's geographical, whether it's just the questions and the types of questions that are askable here. Good absolute versus relative for the stats hounds here. I'm 2 times the rate of ineffective consultations in my personal thing, but I think that I'll go with the number needed to treat of 50 for not being helpful. And I'm not sure if that's because I've shrugged off something or anything like that, but I think the low numbers in general here are the theme, is that people are finding value in this service on both ends of the equation, and I know I certainly do. The needs for referrals as well. That's 51 and 52% you're seeing up in the top row of the table data there, avoided a referral. And I think that's sort of one of the main things, if you were to articulate why eConsult to begin with. One of them is because, in general, people want information in patient care, and sometimes it's less germane to a discussion directly with the patient. Sometimes it's about the size of the need versus the travel and versus other things, saving people trips. And if you can avoid a contemplated physical thing, and what underpins this referral word here is time off, travel, parking, waiting after you park, waiting for the consult. All those things are baked into that simple word there. And if these things can happen in 48 hours or 72 hours over eConsult to answer a question meaningfully, I think that's dynamite. Originally contemplating and still needing it. Yep, absolutely. This is a good way to use this as well, to say, I think this is something I just want to make sure. I think for a quick thing, better than a fax that gets lost, better than an email that gets lost, because this is a consolidated and useful inbox. And the little ones down below, maybe does this person need a cystoscopy, or, if I might say, consider this, and if it doesn't work, I'd be happy to see the person in the future. This fits with my sort of concept of these numbers, where a handful of people do bubble up de novo from the eConsults. So only our AI overlords will be able to parse this list as I roll through it here. But you will see, my eyes pick up PSA and LUTs and microlithiasis and things. And these are literally my most recent 100 consults. And you see, this is just to show that there is a little bit of thematic stuff there. I probably could have spent some time coding a little bit more, but this is probably a bit more effective in telling you what comes through. And these are not going to add up to 100. These are the 5 and more incidences in my determination of the themes in my last 100 eConsults. And you're seeing 2 clear winners here at the bottom, and I'll riff on those in a few moments. Incidental findings on imaging and what's the importance of this? How should I respond, or do I need to do something different? And then the various types of PSA. For those not so familiar who aren't in the medical zone, prostate-specific antigen screening and identifying risk factors for prostate cancers. UTIs and lower urinary tract symptoms, that's LUTs in my parlance. Lots of those questions as well. Cancer surveillance things. And you'll see down below, occasionally, should I scope this person? Sexual dysfunction, surprisingly, maybe not surprisingly, but I think surprisingly somewhat rare. And then something I've grouped as side effects of cancer. So this is what we're seeing. And I think this feels reflective of what I would consider a reasonable breakdown of things in our clinics. There's probably a little bit more of the lower urinary tract symptoms, a little bit less of the incidental findings. And I think that is the appropriate thing. Small questions needing low resource use issues. So I should put asterisks all over this stuff. I think people who have questions about the care of their patients ought to have access to explanations or other opinions for those. So everything's great for an eConsult if you feel like an eConsult would be useful. And so I certainly wouldn't suggest to anyone that avoiding an eConsult for some reason is not great. And this particularly is going to apply in a couple of slides when I have a slide that says maybe not great for eConsults. The PSA questions are usually not the classic ones. Typically, a referral for an abnormal PSA involves a discussion of risks around what it means to get tested for that. I think that's something I would consider a sort of a negotiation type of consult that maybe requires me parsing things and maybe not amazing. But what do I do with this one PSA? Or it's 20 years after his treatment for cancer. What do I do with this PSA? Or should I get a PSA? And when in this person whose dad had cancer and he's now 41 years old? Excellent use of quick bits of advice or guidance without having to put the patient through the ringer, as I described before, just to hear it from someone else. Asterisk time again on the incidental imaging. I wish that Blackburn Muse, KMI, Kenty, and the rest had uploaded their images onto the provincial system, but oftentimes we're sort of stuck with the reports. but there are keywords in reports that mean a lot to me that may be confusing otherwise. And I'll my next slide is going to be those things. So even though I can't often see the pictures, sometimes I can sneak through and find a CT scan on my own system. I think the pattern recognition of my life looking at these things tells me when something is a yes or a no. The shared care thing, I think urologists, and you may agree or disagree, I think urologists are not amazing at the shared care of cancer surveillance things. I share clinic space with colon and lung and breast oncologists downstairs at the cancer center here. And I'm always amazed to overhear, this person is 2 years after some major intervention. Here's what I would recommend for their primary care provider down the line. I think, geez, that sounds incredibly appropriate. And then the next person in a clinic is someone 14 years after a prostatectomy who's having their PSA checked once a year, and nothing's going to change at that point. And even if it does, there's an algorithm to go through. A change after on cancer surveillance does not mean an emergency. So I think having a route back into specialist care is probably appropriate and would probably shave thousands and thousands and thousands of visits off. And sometimes in the eConsult world, to say, hey, what does this mean, is just enough to say, yep, stay the course, or bring them back into the fold. One of the common clinical things is I've tried this, or this person's got a little bit of cognitive change. Am I cool to use this particular OAB medication? Or this person's having a bit of dizziness. Is it cool to use this particular prostate medication? Or should I combine overactive bladder medications with bladder outlet things? I think, calling on some of the remembered experience of our practices for those things, I think is a good and excellent use, in some of the more common ones. And intended course of action, sometimes the next two are sort of the same. Intended course of action, there's lots of those, as you saw. Probably 50% of those things did not necessarily result in a new consultation, and that's because you say, I think I'm going to do this because of aspect Y of the patient's care, and you'll either say, yeah, that sounds like exactly the thing to do, or maybe even do a little bit less or do a little bit more sometimes. I don't know how often this happens, and I quasi hesitate to say patient wants opinion, because I don't think that's a specific reason to call on anyone different, but sometimes just diffusing things. I certainly know that I ask for a lot of second opinions from my colleagues in hairy situations, and sometimes it's a case where it's clear the course of action is appropriate, but you get an eyebrow raise from someone, and sometimes just having a little broadening of the people who've said this is the good course of action feels better. I use the word incarcerated here. It's a big deal transporting people out of our facilities who may or probably don't need a physical exam. A lot of these things are, in my experience, and we've looked at this a little bit, pains and urinary tract things that do require a little bit of sort of explanation, first principles, negotiation type stuff. So they're not always great. But any way to save someone from having to make a trip. And when I say incarcerated as well, I probably should have put some commas there. I think somebody who just happens to be further away, lots of people coming from Cloyne and Bancroft, and it's just a bigger deal to put $100 of gas in your car versus $3 to come from King Street here in Kingston for the same problem. These things actually matter, and there's a lot of resource constrained people out there for whom a trip 18 minutes down the road from Napanee is something that has to be planned and added to the fixed income budget for that month. And I think if you're sometimes willing to have a little bit less face-to-face, then I think eConsults, and in this case telephone consults, are outstanding for those. And maybe punishing those if there is a lower remuneration, which I personally couldn't give two about. Incidental imaging findings, just to put a little medicine in here, like there was like 10 or 15 testicular microlithiasis. Very common to get a scrotal ultrasound, quite reasonable in somebody with some discomfort there. And you see these little speckles in there, and it's usually read as small calcifications, cluster of calcifications, microlithiasis, consider urology consult. And my universal answer is just my exposition on the fact that these are associated with but not causative of testis tumors and require no specific follow-up unless there's some anxiety, in which case do it again. But these are perfect for not creating a gulf, because when you say I'm going to send you to the specialist about your testes because there may be something bad there, that is a particularly rotten a couple of weeks for a 23-year-old, not to pick favorites among patients and phenotypes and risks. Renal cyst, another classic one, abdo-pelvis stuff. What do I do with this lightly complex renal cyst or this slightly open renal pelvis that I found in the workup of something else, a gallbladder that shows? We can often provide a little bit of context here. Who might need a CT scan? Who might need a high five and don't look again? That sort of stuff. And the PVR thing, post-void residual, always tricky. They tell them, our radiology friends, to drink 2 liters of water and don't pee when you come there. So people are universally sweating with massive overfull bladders when they come there. And I think that is a risk for not emptying well. Just like if you put a brick in my hand, you're probably not looking at me right now, but my arm's extended. And if you put a brick in my hand, I'm going to have a harder time with that one than my closed elbow here. And that's just because I'm super stretched. I don't trust those post-void residuals super well, but I'm happy to repeat them in clinics, and I'm happy to sort of risk stratify whether I think it's a big deal or not a big deal. Not so amazing for these things. And again, I should have put a higher up asterisk. Everything is fine if someone is seeking advice. I think, I'm here to know what I know and share what I know, and acknowledge that I don't know a huge swaths of things myself. And so I simply find that sometimes a lot of the action is really talking to people and saying, this is why I think what you've got is an issue. This is why we should be doing this. And I don't think me pawning off that sort of discussion and negotiation is necessarily the best use of your time for these. So when we see people, a 41-year-old with erectile dysfunction, that I know exactly how that conversation is going to go, but it's 15 or 20 minutes of really riffing on things to bring a patient on board with what I think the situation is. Doesn't go well with no eye contact and no in-room stuff. Pain, I've had a few very appropriate, post-procedure pain things. Pain as well is a lot about, as you know way better than I do, a lot about putting things in context and describing the mechanisms, how pain and chronic pain arise. Again, a rubber stamp on an eConsult, maybe not always the best thing. And of course, when people belong in urgent care or emergency rooms, that's not always amazing. Prepare or not always helpful, as in I can't provide you help other than saying I think this is out of our urgency. Phones up if you got cameras on there, because there's a few things that I think are very useful in these specific questions. This is the real distillation of our current Canadian Urology Association PSA and prostate cancer screening. It's, I think, a very reasonable read, and it's only about 5 pages, and it considers all of the good and all of the bad. So this will take you to the COA guideline if your phone is the kind of thing that does this. And if you're having the slides or watching later on, I'll leave it up for a few extra seconds. But you can see here at the very basic level, we have a risk stratification here that says consider alternate things to every year PSA, and then find the times to send along. This is a recurrent urinary tract UTI American guideline. It's a co-guideline with the Canadian one. It's longer because the American ones are hugely long and expository, but I've learned a ton from this one, and I've used it in my practice a lot. So I see a fair number of these consults in eConsults saying, what about the non-pharmacologic things? Do they work? What should I recommend specifically? This is a good document to sort of pull through that stuff. Short version, I'm a big believer in 2 liters of urine output for anyone with recurrent UTIs. I'm a believer in cranberry purchased at Costco or Loblaws in bulk because it's cheap and it's better than boutique expensive ones. And I'm coming online as a huge fan of local vaginal estrogen therapy. I was on my gynecology rotation in med school at Mount Sinai Hospital, the apex gynecology center at the time in the city. In 2002, when the Women's Health Initiative dropped that week, and you thought the Jerry Lewis telethon was on, the phones were ripping. It was a wild, wild time, and I think we're sort of finally clawing back some vaginal estrogen. I think I won't go panacea, but man, it makes a big difference in a lot of people. And lastly, or second lastly here, you'll see that microscopic hematuria has gone wild. Instead of just if you're 40, do this. Or above, we're risk stratifying and trying to avoid a few scopes in people. Urologists, to butcher Charlton Heston, you will take our scopes from our cold dead hands, but not everyone needs this kind of intrusion. And so the main things here, and you can look at this on your own time as long as you would, that those low risk people, non-smokers, less than 50 or less than 40, with only 3 to 10 red cells per high power field, we can avoid scopes in them. And remember, a dip is not a hematuria. Microscopy, absolutely. That's where we make decisions. And I think a few people are now starting to push back on referrals when they come in with 3+ or dip blood instead of microscopy. Last but not least, I mentioned a 41-year-old with erectile dysfunction and knowing exactly how that talk's going to go. And by that, I mean, I'm going to tell this person 98% of the time that I don't think there's a metabolic and neurologic reason for their erectile dysfunction. And to respect them, the levers that I have as a urologist, considering the, to me, an erection is blood and nerves with a little sprinkle of libido on there. But Dr. Bossio is wonderful. We bring her in to do our teaching rounds once in a while. I put her name up there, not for particular, but she's the only game in town and has the whole team of psychologists and social workers with her. I'm referring a fair number of these people there. It's not easy to do, but for those people who are waking up with erections and not getting them situationally, they're probably going to benefit from the quick chat with them. Not covered, of course. That is the last of the slides I've got. I appreciate your time here, and I'm more than happy to riff on anything as would arise.
Great. Well, that was a fabulous overview of what works well and what doesn't work well as it relates to eConsult. And it sounds like you're having very good success in referral avoidance at a 47% rate. As it relates to people that still need to be seen by you in clinic, do you find it's often useful to have an eConsult to make sure that the patients are appropriately prepared, or that you've got the right tests in front of you when you're actually seeing the patient in clinic?
Yes, they come up now and again. I think they might have been in that sort of 22 or something % of things that sort of didn't made a difference but didn't change the consult. And I think that's probably what we're getting at in those cases. I think a referral coming in and me sort of scribbling in my rotten scrawl, please get CT scan, that lacks a little bit of humanity. And I think an eConsult, I'm happy to do it because it costs $0, of course, to the system. But I think buffing things before a consult, I probably would get a CT scan instead of an ultrasound. I would suggest repeating that PSA in a couple of months before this person is seen again. I think those are good uses because, if we looked in the clinic, we would probably find that a double-digit % of the time, the proximity between the test and our discussion would probably be better served with a tighter time interval. And we often are repeating things and see again in a few months. I think clustering these appointments is generally because of that. So I think it's a high value thing. I'm sending this person along, clarifying if the suite of information that is coming with them is going to do the job.
Great. So I'm just going to look to the audience to see if there are any other questions on the call, and maybe we wait for people to come up with some ideas. Another quick question. It sounds like maybe you can tell me a little bit about the turnaround time between eConsult and your response to eConsult. So what does that currently look like?
Yeah, so there are a couple of ways that we receive to do it. You can have a consult as per message or a daily digest. I choose the daily digest, which means I get an email while I'm sleeping. I despise email, and it's nice to have them not happen in the day because I'm also super impulsive and would I try to do them the day after. The only times I think I've ever been more than 5 days, which I think is twice, I have forgotten to turn it off when I've gone on vacation and then check my email, which I shouldn't have been doing 4 days into a vacation, and realize that there's a pending consult, and I'll usually just try to sort of knock that out there. I try to do them the day of. My sort of morning personal workflow is that I get up and start fussing with the email at a quiet time in the morning. Fridays will generally be dealt with sometime before the weekends, and I try not to do them over the weekend. So there are a couple of sort of reliable teammates who probably have a workflow that is to spend some time sending out the consults, batching those tasks and sending out the consults on a Friday. More than happy, and they're done by Monday morning. So call it 48-hour turnaround time as my median.
Excellent. And, if people are just, I guess I'm looking for your thoughts on if a primary care provider is uncertain about sending an e-consult, is it the right thing to do? Should I be bothering? Your advice would be?
Yeah, I think it may threaten rising that to 4% up to a 6 or something like that. But I think we're all people. I have no moral judgments of those things. I think anytime someone has a niggling question, then having an outlet like this is a good idea. It'll probably land better than a phone call to the on-call person, which everyone knows the fidelity of information transfer there is not so great. But
Right.
our eConsult workflows are pretty reliable in getting from A to B. So, if the risk is, not getting a super useful bit of information, I think that's fine. But hopefully there's nothing about, am I asking too simplistic or too whatever a question? I mean, I think we are probably burdened with our version of the curse of knowledge, which means we have very little knowledge in most of medicine, and we think that everyone knows exactly what we all do in our own world. So things that are sort of routine or obvious to us, we need to be smarter at things. This is actually not common knowledge. This is my little practice pearl. So I'm always happy to riff, even if the without apology, even if the riff or the question is a mild or a head scratcher one.
Great. Well, and it sounds like a really good opportunity to share information as you've just done this morning during the webinar, right?
That would be
with
my
useful links.
own feedback on myself, is that I may be a little bit, more expository sometimes. I may try to answer the direct question, and then I'll sort of, give some contingencies and some what ifs, and I'll try to attach some of these guideline documents here and there, especially at the provincial level. We see some of the provincial oncology ones here, as well as our local crew for the general urology Southeast.
Great. All right. Well, I'm just looking at the clock and it's coming up on 8:59. We want to be respectful of people's time. So thank you again for your fabulous presentation this morning. It was succinct, but very thorough in terms of what works for a good e-consult and how quickly the turnaround time is for responses. So we really appreciate your time this morning.
I appreciate the ability to be on the service. For those who are here, thanks so much. For those watching whenever, I hope your chair is comfortable and you found it informative. All the best.
Thank you. And for those following up on our series, next up we have neurology, which is going to be coming up on May 27th. And our last in this, what I'll call first series of eConsult webinars, will be child and adolescent psychiatry. So we welcome your feedback as always, and are now taking recommendations for future content for potential eConsults. So thanks for joining us, and stay tuned for our next eConsult webinar.